Thank you, and good afternoon. I'm pleased to see everyone's been off to get coffee and sugar, because hopefully you'll all be awake. But you only need to be awake for the first slide, because I make sure that the message is on the first slide, so you can then kick back, relax, and just look at pretty pictures. I'm Simon Swift. I run one of the companies within Methods Group. Some of you, I know Swindon, Lincolnshire, etc., know my colleagues from local government practice. We're a separate gang, and we play with numbers. So I'm going to be talking about data. We come from the NHS. I ran this team in the NHS for 4 years, and our purpose was to work with doctors and managers and help them make decisions based on data and intelligence, which was a slightly heretical concept in 2009. The world has moved on a little bit. That team, unfortunately, was left orphaned in the bonfire of the Quangos in 2012, and I lifted the team out into the commercial sector. We do the same thing, which is help people make decisions based on meaningful analysis of data. Most of our work still with the NHS, but increasingly the boundaries between NHS and particularly social care are becoming increasingly blurred. And you know, we found that what we do, our methodologies, our ways of thinking, translate. So we do a lot of work with police, with defence, with industry, all sorts of places. The bluff, the bottom line up front of the talk is using data about citizens. Our data, we have a lot of data. My CTO told me the other day we have 35 billion rows of data, which is really boring. I agree with the previous speaker. I'll explain why on the next slide. But we can understand what demand there is from your population on your services, by whom, for what, where, and when. And if you know that, you can plan. You can proactively intervene to help those who are most vulnerable, and you can improve the services, you can improve the experience, and you can be more efficient. Now you can all go to sleep. That's what I'm here to tell you. I have a mantra. There is a lot of data in the world, increasing. There's a lot of evidence of the impact of interventions if you know what to do, where, and how. You bring those together through the brain of a half-decent analyst, you end up with information, which, like data, is not much use. It doesn't do anything. It's input to the magic, which is interpretation. That's where you get the people in the room which the data covers. So you get you. You get people from your population. You get providers, social care, healthcare, third sector, hospices, whoever's involved. Get them in a room, lock the door, and have a bloody great argument. What does this data mean to us in the context of policy, priorities, demands, mandate from up top, demand from down below? All right, now you're developing some meaningful intelligence, something which a decision maker can look at and go, oh dear, I thought I was going to do that, but now I have to do this. That decision is the magic, because that allows you to drive a change, and then you use the data that comes out the back end of the process to monitor it. How many people have run a massive change program and then a year later looked at the outcomes and go, ooh, and stopped it, cut it dead? Very few in the public sector, because we don't do the monitoring properly. So you can cut some stuff dead. We've done that quite a few times. The other thing you do is you tweak your intervention. We thought this particular thing would really make a difference. And you look at the monitoring data, it's not really done much. That was a bit of a waste of time. Okay, let's tweak it a bit. Let's see if changing that bit works. Or even better, let's do an alpha-beta test. We'll do that bit over there, that bit over there, and see what works. So that's my world. So I'm here to talk about population health analytics, population health management, which is just a particular facet of using data across a whole population. And the reason I'm particularly pleased to have been asked to come and talk to you is because this is not a healthcare thing. I come from healthcare, I was a surgeon, I did that about 10 years, and then I realised the idea of taking a knife to somebody to make them better was a bit odd, really. So I went off and became a health economist, so now I understand, like, healthcare world, I understand data, and you put them together and you end up with fun stuff. Population health is about looking after the health of the whole population. The NHS, healthcare, are providers. They don't have the remit to care about the health of the whole population. Who does? Local government. Hello. So population health management is about improving the health of the whole population. You use a lot of data to understand how to design services, where to put them at a planning and strategic level, and then you can do more funky stuff to actually identify individuals who are at risk of specific types of event. It's always risk of. Somebody asks me, what is the risk? The answer is, dunno. Risk is not a generic term, it's risk of. And then you can say, these group of individuals all have a high risk of a fall, being admitted to residential care, whatever. We can model just about anything. Sometimes models don't tell you much, but we can try. And then you can design services for those individuals and you enroll them into particular interventions. Sorry, I thought I clicked something by mistake. Where that individual can be impacted. If somebody's got a 99% risk of falling over at home, you don't go and spend a ton of money on something to prevent falls, because it ain't going to work. The risk is baked into that individual. What you do is you do something different, which will manage the fact that they're going to fall. I'll come on to that more a bit later. So you use this kind of maths to identify groups of people with a disease, with disease combinations, with particular risks, and then you design care around them. Lots of tools, you bring the data in, you cut it, you slice it, you dice it, you do modelling, da-da-da. The whole idea is to identify groups and individuals who are at risk of particular problems, and a problem might be, one of the commonest ones we do is people who are at risk of being really expensive. Yeah, that's easy to see. The underpinning you need for this is a linked data set. The more we know about individuals in the population, the more we can model, the different kinds of risks we can model, and the more accurate we can be. So you start down here, SUS, that's healthcare data. That's everybody who goes through a hospital, leaves a trail of about 100 fields in secondary user care data set. You add in primary care, that's all the GP stuff. Social care, that's some of your stuff. Mental health, schools, housing, employment, da-da-da. And you start to build this very carefully secure, governed, preferably pseudonymized, I'm kind of allergic to identifiable data, in our data centers anyway, data model. And it looks like this. You have Bob in the middle there, and you bring in all of this data from all of these different sources, and you build a person-centric data model. You link it all together so you know all about Bob, and then you can start to identify other people who are like Bob, or a bit like Bob in some ways. And then you can start to do all sorts of stuff. Segmentation is about identifying groups in the population who are similar. It can be really simple. Everybody over the age of 75, that's a segment. Everybody over the age of 75 who is diabetic, lives in ward and controlled housing, and has dementia, that's a smaller segment because you're starting to focus in. The idea is that there are groups of people who are homogeneous. They are the same in certain ways. And then you can design services around them. So that's about planning. That's the first level. The second level is risk strat. And this is about building models to identify the risk of events, specific events, for people within segments. So you've identified this is a group of people where we can improve services. We've identified that group of people. We've identified the individuals in that group who are at high and impactable risk. This is only worth doing if the outcome you're predicting is modifiable. If you can't change it, don't bother. And changing that outcome improves use of resources and experience. We do maths. Do you want to see it again? Don't ask me what Breyer's score is. I don't know. I have a professor of statistics who does that for me. The idea is individual, at risk, with a proven intervention. You put them together, magic happens. One thing is, for everybody in the population, there's a continuum of risk. Some people are way up there. Whatever you do, it's going to happen. Some people are way down there. The black line on this is actually the ROI curve from a published study that said Professor of Statistics did. And what we see is that even from people who are really at very, very low risk, this was falls in the community, you start intervening and you can impact risk of somebody who's only 1 in 10 risk of fall over the next year is what this is. Because a falls clinic is cheap and the cost of a fall is massive, both from a financial point of view and from experience point of view, you can change it. But what you do is you do different interventions. People up here, 0.8, 0.9, you're not going to put them through a falls clinic because, frankly, they're going to go to ground. What you do is you send in the fire brigade to nail down the carpets. You do a slipper exchange. You do those kinds of things, but they're going to fall at some point. You might be at the sort of end-of-life care plan stage, it depends. People in the middle cohort, that's where you can really make a difference. Yeah? And those are traditional falls clinics, stuff like that. People at the bottom end, that's more about awareness, exercise, that kind of stuff. This is, I'm missing a bit. Oh no, it's not there. There's meant to be a big arrow on the right hand there. This is evidence from a study that we did in New York. They identified a segment of people, everybody who was likely to cost more than $50,000 in care across health and social care over the next year. And they thought, that's a lot of money. What we're going to do is we're going to pay for a couple of staff who will reach out to these individuals and invite them to come to our centre so that we can do a proper review of everything that's going on with that individual and make sure that they're getting everything they should need and everything's properly coordinated and organised. What happened was a 27% reduction in inpatient care cost. Spent a little bit more on prescriptions and outpatients because they were actually putting more input into these individuals, and a tiny increase in emergency room cost. Don't ask me why, I don't know. The net impact was a 22% reduction in cost for the highest cost group of patients over a year. That's a lot of money. So where do we start? Well, that's kind of complex, because that depends on what matters to you, what you're being kicked about, whether that's kicked politically or kicked to the local gazette, what your population's yelling about, or it could be what the data says, though that's quite rare. So this is an example. I'm going to trot through a bunch of slides now, because these are just eye candy. This is risk segmentation for people over the age of 75, and we're looking at grey bar is cost, turquoise-ish, teal bar is count of people needing emergency care, and the blue bar is volume in the population. And everybody goes on, it's always the elderly. No, it's not. It's working age adults. That's where your volume is. We can tell how sick these people are, how many different conditions they all live with. And by the time you get to 75, nearly everybody's living with 5, 6 different multiple conditions. We can do maths on that, and we can start to identify frailty. Who in your population is frail? So what? That's information. But you map that by lower super output area, and you start to go, ooh. We can tell who's expensive, and that's just a chart by age But actually, if you look at that by GP practice, by ward, by street, you can start to really get a bit more granular about what you do where. We can identify the individuals who are likely to be high cost, and that's where you have a list of people and a phone, yeah, or legs. And you have people who go and visit and outreach and inreach and all those kinds of reachy words. These are people who were discharged from hospital. This is data that is available before they're sent home. This is by GP practice. Those two people at the top had a pre-discharge risk of being back in hospital within 30 days of 80%. Did anybody know that before they sent them home? And if they did, what did they do about it? The answer is they didn't, so they did nothing. What a waste of money. And what a crappy experience for those two individuals. And you can see the spectrum's quite high. Got a lot of people, 20, 30% risk. Yeah? Not good. Not good. Not good for people, not good for the system. This is, can't remember, somewhere in East Anglia. But here we're looking at the relationship between staying longer in hospital than you should and deprivation. Why does being more deprived mean you spend longer in hospital? Discuss. What could you do about it? Aha. So how do you start on this journey? We have a process which will take you from, that guy taught something that might be interesting, to live services. I'm not going to talk about it today because it's quite long and complex and boring. But you start with convening, and that's what you can do as local government. Because you can say, you, primary care, yeah, LMC, whoever, you, hospital, you, mental health trust, social services, yeah? Get them all in a room, lock the door, have a barney. Yeah? We're going to do something about this, and we, as the local authority, are going to hold the ring. The first thing you need to do is talk about risk and benefit transfer, because the trick to making this work is understanding that you're going to spend money over here, and the benefit's going to happen to a different organisation over here. Unless you're willing to have that conversation, people don't play nice. Thank you.